Welcome back to our World Patient Safety Day special on diagnostic safety. I'm your host, Dr. John Fitzsimons. I'm a pediatrician with CHI at Temple Street, and I'm clinical director with the National Quality and Patient Safety Directorate, and I work in quality and patient safety education with the RCPI. In part two of this special, Professor Eva Doherty and I speak with Dr. Hardeep Singh on diagnostic excellence. Dr. Singh is a professor of medicine at the Center for Innovations in Quality, Effectiveness and Safety, based at the Michael E. DeBakey VA Medical Center and Baylor College of Medicine in Houston, Texas. Dr. Singh is also the co-chief of the Health Policy, Quality and Informatics program at IQueSt and director of the Houston Diagnosis Improvement Safety Center. Hardeep, you're very welcome to this episode of Walk and Talk Improvement.
Thank you. Thanks for having me.
We wanted to ask you a little bit about this concept of diagnostic excellence, which is something I think that is emerging in the US as a solution to some of the problems that we've seen in diagnosis. And it's an interesting concept rather than focusing perhaps on the negative side of diagnosis, that we think about how do we make the diagnostic process better. And I think you're one of the people who've certainly championed this idea. Would you explain to us a little bit about what diagnostic excellence is?
Sure. So about 20 years ago, so when we started in this field, I was calling some of these things diagnostic errors, and it just wasn't resonated. Then I started calling it missed opportunities in diagnosis, and it's got a little better. People started understanding what we were talking about. But then about more than a decade ago, after we've done some of these studies initially, we thought what we really need to move towards is moving from sort of error to excellence. And we decided to define the concept of diagnostic excellence. So for us, diagnostic excellence is not just about making a correct and timely diagnosis. It's also about making a correct diagnosis while using the fewest amount of resources. So for instance, if somebody walks into my clinic with a headache, if I keep ordering a CAT scan of the head for every single person who walks into my clinic with a headache, I might find maybe a brain tumor after 500 CAT scans. But that's not good use of resources. So that's one of the reasons we added the concept of making the correct timely diagnosis using the fewest resources. But then we also heard a lot from patients saying that they felt that their needs were not listened to, their concerns were not heeded to. And we added the concept of maximizing patient experience to the definition of diagnostic excellence. So now you've got sort of three concepts. And then one of the important concepts in diagnosis, it involves uncertainty. And it's hard to sort of manage uncertainty at times. And we felt, and this came from some of our work, that we really need to communicate some of this uncertainty to patients so they understand when their diagnosis is more on sort of the gray side, it's not black and white, that things are not really certain. And so we added the concept of uncertainty to the diagnostic excellence definition. And lastly, then, what's good as a diagnosis if it's for a person for who a day doesn't matter? So we said sometimes we have to do watchful waiting. You don't have to jump and do something on every diagnosis. Sometimes watchful waiting is better. I mean, imagine a 94-year-old getting diagnosed with prostate cancer through a elevated PSA, right? That's not really something we should be doing. So that's how we came up with these sort of 5 dimensions of diagnostic excellence, and that's how we sort of think about it in our work.
That's great, and it's obviously something that's evolving and probably will continue to evolve.
I think so. I mean, people sort of want to add their own diagnosis definitions. There's people, who want to also think about it as a quality dimension. So if you think about, the 6 dimensions of quality, you can also describe diagnostic excellence or diagnostic quality in those 6 dimensions of, the IOM dimensions of quality: effectiveness, efficiency, equity, patient-centeredness, safety, and timeliness. So you can also do it like that. But no matter how you define it, it sort of has some certain attributes that go beyond just making a correct diagnosis. So it's not just diagnostic accuracy. It's much more about other things as well.
And we're adding in sustainability all the time here now as the 7th domain of those dimensions of quality. And I think, again, what you're talking about I think helps that, that we can be more sustainable.
Yeah, I mean, it's funny that you mentioned that because I don't know whether you kind of knew this or you just sort of made it up, but we just had a paper on diagnostic excellence and environmental sustainability, sort of trying to sort of tie the concept of diagnostic excellence in the new era of climate change.
Yeah.
What does that mean for clinicians? And so basically what we said in this paper was there's two things that are new. One is we're going to be seeing diseases, conditions that we're not used to seeing. So people in Houston are now going to see dengue, for instance, all these vector-borne diseases that they were not seeing before. So that's one attribute is, I mean, we've got some heat-related illnesses coming. Some of these places, it's hard to sometimes recognize this is a heat-related illness, whether it's, exhaustion or, hyperthermia or whatever it might be. And so one is improving your diagnostic skills to account for some of these climate-related illnesses. And the second is being a good steward, because we know this, right? So we have a lot of low-value care. About, at least in the US, the figures are about 30% of care is wasted. All of that care consumes emissions. So the healthcare system also produces emissions. And if you are wasting resources, you're producing unnecessary emissions. And so we said the second attribute that people need to be thinking about is we got to think about, overdiagnosis, overtesting, overuse of resources in a new way, because all of these things consume emissions and contribute to climate change.
Yeah.
So we tied these two things together, and we just had a paper in American Journal of Medicine on environmental sustainability and diagnostic excellence. And it's funny that you mentioned it today. So.
Congratulations. That's great. Thank you. So Hardeep, I'm a clinician, and Eva is involved in teaching clinicians. I mean, what can we do as clinicians or groups of clinicians or as healthcare organizations to I suppose, progress diagnostic excellence?
There's a lot clinicians can do. I'm going to sort of think about some of the individual strategies first. So one thing we've sort of shown is a lot of clinicians are what we call sort of miscalibrated, in the sense that your accuracy and your confidence in that accuracy are not very well aligned. So in one study, we showed that physicians are overconfident, and even in the middle of very difficult cases, they don't necessarily ask for help. Well, how do you lower confidence and get yourself more calibrated? One way to do that, and that comes from psychology, is you get feedback on your performance. Feedback can help you calibrate better and help your diagnostic performance. So one of the things we are proposing for clinicians is all clinicians should learn from feedback, whether somebody else gives it to you, could be your peers, could be your superiors, or it could be self. You could go and look at your own cases to learn from them, how you perform. So that's one. The other thing we talk about is, we read a lot when we are in training, we take exams and such, but then we kind of don't pay as much attention to the real, we start seeing patients and we don't necessarily keep up with our knowledge. So we said, just like, everybody should, exercise a few times a week, few minutes a day, think of bite-sized knowledge. You don't have to, sit down and study for hours and hours. Maybe 5 to 10 minutes a day, do some cases, do some real cases. And there's lots of resources that are available to do short simulated cases. So it's like a little bit of a simulation that you do every day, or at least several times a week, whether it's 5 minutes or not, or longer. And we call it bite-sized learning with a BYTE, because some of these cases are now digital. And this is a paper that we wrote in BMJ, and happy to sort of share.
Yeah.
The other was about biases, of course, right? We all have biases, implicit biases, cognitive biases. You have to recognize your biases. The other very important thing that often gets forgotten, and we as clinicians, we are used to being sort of the people that we think make the diagnosis. We're the only ones. We think we're the only ones. So anybody who thinks about diagnostic excellence or diagnosis, people think of, oh, that's a clinician problem, or that's a clinician has to get it right. Well, that's not always so, because we think diagnosis is a team-based process, which means it involves patients, nurses, physical therapists, occupational therapists, speech therapists, dentists, specialists. And, sometimes the team will include technology or now, artificial intelligence. So we have to think broadly of what the care team looks like when we talk about diagnosis, because it's not just a single physician or a single clinician. There's a team that's sort of involved. And then lastly, which is, again, an important facet of diagnosis is critical thinking. We don't teach that very well, at least in our medical schools. But that's important because sometimes you have to question yourself. Your patient's not getting better after you made a diagnosis, quote unquote, which you thought was correct. You may have to rethink and challenge yourself. Like, am I sort of making the right assumptions here? And reevaluate. So some of these critical thinking things also need to be thought through. And then we can go on with the organizational strategies. I think all organizations should sort of think about looking for cases. We have several tools now that we've developed to help organizations assess themselves as to how they are performing. One of the tools we developed with IHI, the SaferDX checklist, you just do a self-assessment. Get a team together. If you're a CMO, Chief Medical Officer of a healthcare organization, you organize a team and say, go through the checklist and tell us how you're doing. And it gives you a score and tells you what you're doing well and what you're not. And then you see where you want to invest your resources. We also have tools now to assess organizations on how they are, or how we can get organizations to find cases and learn from them. Sort of improvement and learning, because we think that if you identify, you have a mechanism of monitoring and doing some sort of a surveillance for diagnostic errors, and you constantly learn from them, you then become kind of a learning health system for diagnosis. And that's what we want all organizations to become.
Thank you. That's wonderful. Eva, do you have any questions for Hardeep? Or?
Yeah, I mean, as I'm listening to you, Hardeep, I'm thinking so much about the psychology of everything that you're talking about, the human factor side of this, the cultural side of it, because I'm sure you'd agree, like you'd have to have psychological safety to make all of that, what you're talking about, work. If you have fear in an organization, none of those things are possible. The other thing that struck me too is we spend a lot of time teaching feedback skills, and we use the advocacy inquiry framework from the world of simulation, because we find that works really well, because we find that actually people don't give feedback effectively. They think some people think, if you just say to someone, don't do it that way, do it this way, that's feedback. And then they wonder why people get defensive and don't want to listen. So yeah, there's some of the thoughts going off in my head when I'm listening to you.
Yeah, so let me start from feedback, and then I'll go to other sort of psychological safety issues you raised. You're right about the feedback part. In fact, one of the studies where we pilot tested a strategy to provide feedback on missed opportunities to clinicians, we really had to train the feedback giver. And so we engaged the Center of Professionalism within the organizations that came up with sort of a toolkit to try to make sure that the feedback is given, non-punitively, confidential, make all those principles that you're thinking to ensure psychological safety and giving it right. And of course, it only works if it's done well, which is, I think, what you're trying to get us to think about. We actually then conducted surveys with people, how did they get the program go? And most people liked it. The feedback giver as well as the receiver said that this was a good experience. It felt more like a debrief about a case rather than somebody coming and tell you that you did something wrong and you should have done it the other way. And so we learned quite a few lessons that I think could be useful. But again, it requires time. A lot of people don't have that much time to sort of sit down and discuss these cases. That was a big challenge in our study. And then you mentioned psychological safety. Absolutely, right? So if you are a clinician, you're not always reporting these errors because you don't want anybody to find out what happened or what your colleague, if your colleague missed a diagnosis or something. So we are trying to figure out how we can get clinicians to better engage in either reporting or learning. And it's been somewhat of a challenge, but there are several things that could work. One is changing the language around diagnostic errors, and we talked about this in the beginning. We now have started thinking of them as not diagnostic errors or maybe even missed opportunities, but more like learning opportunities. In fact, there was a study where one of the fellows used this term diagnostic learning opportunities in a pediatric hospital and asked the faculty members to report cases through an alternative system. And sure enough, within 6 months, had 100 cases of diagnostic learning opportunities because the way she asked a question was very sort of psychologically safe. And because she was a clinician champion, was not asking for a lot of information. All she wanted was medical record number, patient name, and what was the learning opportunity, one line or a few lines. And people started reporting. They felt comfortable doing it. The language was appropriate. There was an alternative mechanism that wasn't getting lost in the organization. And they had a right person who had built a trust and rapport with them to learn about their cases.
That's so interesting. You're reminding me, I wish we could all just move from, talking about near misses to talking about good catches, and switch it that way and to, frame it in the more optimistic, learning language, if you like, rather than punitively, framing it in terms of mistakes and misses and all this.
Yeah, we haven't had a lot of only now, I would say we've had some progression thanks to some grants funded by AHRQ, Agency for Healthcare Research and Quality, on what we call Safety 2, where you learn from things that are going right and everyday things. And so we're still early in that, learning from pockets of excellence, learning from good catches, learning from Safety 2 journey, at least in the diagnostic space. So I think the field will get more. I know some folks who are doing work in this in Europe, and I think the field will probably advance over the next few years.
Hardeep, one last question perhaps from me, just on, I suppose, where you see things going in the future with artificial intelligence and machine learning and all of these new tools that information technology might be able to provide us to assist and enhance diagnosis, and just wondering what your thoughts are on that and where that's going, how fast it's going, and maybe some of the pitfalls as well.
Sure, there's quite a lot of explosion of AI and diagnosis conversation in the last few years, and I look at it in two different buckets. One is sort of the visual bucket. So AI is getting really good at reading, radiology, reports and pathology, dermatology, endoscopy, retinal images. So anytime there's a picture, I think AI is doing pretty well, and the diagnostic space in that is getting quite advanced, and I think AI is doing well. The second space is clinical diagnosis, which I think after ChatGPT a couple of years ago, the space has exploded, and lots of studies showing how great ChatGPT is in all these cases from either New England Journal or exam cases, and doing pretty well. I think there's some conflicting reports on how it does well in real world practice. And so there's still sort of studies coming out, and there's like one new one every week. I can't even keep up. I think we're a little early in clinical diagnosis space. And for me, it has been mostly around, most of the diagnostic errors we see are related to some sort of a history or a physical exam issue, or somebody not ordering a test based on the history and the exam. And so, if you can't listen to the patient and get a story out of the patient, or examine the patient. ChatGPT may not be very useful for you. ChatGPT is not going to make your diagnosis because you didn't talk to the patient correctly or you didn't take a history from the patient. If you have the history and you do a physical exam and then you need help from ChatGPT or even Google, I mean, that's when all these information resources are useful to you, right? Because then it tells you, here's all the data. So the more data you provide these differential diagnosis generators or search engines, the better it is for it to point you in the right direction. And with that, you have to know when to seek help. So the study I talked about earlier, where we showed that clinicians often don't ask for help, even in the middle of very difficult cases, shows that even when you offer these tools to physicians, clinicians, they may not use it or they may not know when they need to use it.
Yeah.
So that's another challenge we have to sort of overcome. But I think overall it's exciting that there's been a lot of progress in this field over the last couple of years.
Dr. Hardeep Singh, thank you so much. And up next, in part 3 of our World Patient Safety Day special, I speak with Dr. John Brennan on diagnosis from the perspective of a GP.